Thank you, Mr. Chairman, and thank you, Dr. Dietz, for your helpful testimony. It's packed with information, so I want to go back to a few statistics that I think should be highlighted. You had mentioned that approximately 25% of our medical costs, either now or in the future, will be related to this problem.
25% of the rise in medical costs between 1987 and 2001 was attributable to obesity. These are data from Ken Thorpe at Emory University. The implications are that that's going to increase further if you think about what the prevalence was in 87 and what it is now, and the impact that the wave of childhood onset obesity is going to have on adult disease.
Do you have, let's say we could cut that increase or the total prevalence of that statistic in half by the variety of things that will be suggested today, or a national awareness that this is serious and an implementation of both old and new ideas about nutrition, education, access, as you're suggesting. What would the potential healthcare cost savings be to our overall system?
Yeah.
Or pick a number that's potentially attainable in the short run.
Well, we know that from a paper that we published several years ago that the annual adult costs of obesity are about $117 billion per year. If we were to halt the rise in prevalence, I think we'd begin to see a decline in those costs. If we could cut obesity in half, I'm not sure that we could reduce those costs by half, but we could certainly have a big impact in that reduction.
I think as we move forward, particularly in the legislative year, this is going to be a very important number to try to quantify. What is the potential improvement of health outcomes as related to health care cost reductions, particularly in public programs, that we could see if there were broader investments like we're all going to talk about today in nutritional outcomes. So if you can continue to parse your data to come down to some number that, of course, will depend on a lot of factors, I understand that. I think that will be helpful to quantify, to get our mind around what the potential here is, not only just in terms of well-being of our population, but healthcare cost outcomes. Another statistic you had mentioned, and you'd actually addressed it a bit with Chairman Baca's question. You said 60% of adults are either overweight or obese, 30% of children. Now, type 2 diabetes, or the rise in it, if I understood you correctly, was basically unheard of in this particular category of children just a few short years ago. Related directly to the obesity problem, or are there other factors there?
The main driver is obesity. In the adolescents that I saw clinically when I was still in Boston, there was generally a family history which predisposes those individuals to type 2 diabetes.
But something must trigger that if we hadn't seen it before.
If they hadn't been obese, that would not have happened. Coming back to your question about cost, it occurs to me that we can provide you with some data from the Diabetes Prevention Program, which showed that clinical interventions for preventing diabetes were quite effective. They lowered the rate of new onset diabetes by about 60%, which was more effective than medication. And I believe that a cost calculation was done on the cost benefits of that intervention, but I don't know those data off the top of my head.
That would be helpful for us as a committee. I think, if I could be presumptuous and suggest that, Mr. Chairman, that we drive towards some number like that that gives Congress a quantifiable goal as a measure to potentially reduce costs in the name of health and well-being. I want to end, one more question and I'll make some editorial comments, but could you address the benefits of local food markets as related to a trend toward or a growing paradigm a new paradigm as we look to combat obesity and overweight, or the problem of being overweight? How helpful will this be?
Well, two slides that I didn't address that are in your handout include the 6 target behaviors that we think are going to change the prevalence of obesity. Among those is fruit and vegetable consumption. We know that people who eat fruits and vegetables tend to have an earlier satiety, because satiety, fullness, is regulated by the volume of food, not by the calories in the food. And fruits and vegetables, because they have a high water content, are more filling. And one of our interests is in how do we increase fruit and vegetable consumption. And one key strategy is increasing access. A great example of that occurred with Kaiser Permanente in Northern California, which instituted fruit and vegetable farmers markets in all of its major clinics. And these were located between the parking lot and the clinic. So employees who passed by could buy fruits and vegetables, patients who passed by could buy fruits and vegetables, and those fruits and vegetables were produced by small farms in the Sacramento area. So it was a threefer. This benefited employees, it benefited patients, and it benefited those small farmers. We believe that farm-to-market programs are an important strategy for increasing fruit and vegetable intake, and your initiatives in this regard are to be applauded.
Well, again, thank you very much for your testimony. Mr. Chairman, if I could add just right quick, I want to point out that the gentle lady from Wyoming made some very important observations. When I was growing up, my mother was an extension educator, 4-H club leader, and some of these processes that we're trying to turn the clock back to are so normalized, and with a lack of continuity in family life, disconnection from a rootedness in any particular community, the stresses in modern life, I think, are the sociological factors as well that are underlying this problem. But thank you very much for your testimony.
Welcome. Thank you.